why this women or community is not taking the medical treatment loan. It's good for them, but we found lot of limitation that there's no community mobilization. So most of the community members even don't know that this is an opportunity. This is also very top-up feature that existing borrower. So if I'm a microfinance borrower that I borrow, only I can take that loan. If I paid my loan, I am not eligible. There's also complex disease verification. I have to go to the district, to the doctor that which is assigned by BRAC. They give me the, they look at me, they give a document. I have to take to the BRAC manager. So, but your catastrophic health event doesn't wait for that. If there's somebody in a cesarean section or heart attack that they need the treatment, this process made it very slow. So most of the people are not interested to take it. There is a repayment was that within 12 months you have to pay it back. And there is and also that there's a short loan ceiling. So it was only around $300, which is nothing if you really go for treatment. Next. So what we did an implementation research, we did survey, we talked to the branch managers, and then we revised it. And after the revision, you can see that the uptake, we call it MTL plus. So the fast food medical treatment loan, we revised it, and then there's a medical treatment loan plus, then we did a randomized control trial. We randomly selected several areas where we offered the old one, and then somewhere there's the new one. And you can find that how the acceptance, the loan, the borrower has been significantly increased. Next. Sometimes we know the solution, but we do it badly. Next. So, the preterm birth is a major reason for newborn death in Bangladesh. This is almost 30% babies were born before 37 weeks and they die. Next. So there is also the 30%, next. So there's also very simple intervention. It's called kangaroo mother care, that the preterm baby, that they will hold the baby, the mother, and then it shows that a lot of RCT have been done globally, and it shows that it reduces the neonatal death. So that Bangladesh government introduced that in the secondary health complex, that this kangaroo mother care. Next. And we found that again the acceptance is very low, and and then we looked at the fidelity. The fidelity is the way the kangaroo mother care supposed to deliver, whether they're delivering that or not. So we found that 78% of the neonates made the criteria to be eligible for kangaroo mother care. We found that only 78% neonate the kangaroo mother care position, because mothers were not counseled well that you have to hold certain weight. Mothers did not maintain 87%, and 67.5% were mothers were counseled properly. We look at that you have to measure the temperature, because newborn care, one of the either they have the pneumonia and other disease is only 30%, and when that they will discharge, whether the newborn baby is doing well or not, the discharge, there are certain discharge criteria that's only met by 11%. So although it is a very simple intervention, but the execution of the intervention was very, very poor. Next. Sometimes we know, but we do it very reluctantly and relaxedly. Next. So what I'll talk about the two, the lost in care and the premature implementation. Next. So the direct observed treatment short course, the DOTS for tuberculosis, is a very, very effective intervention globally, that you will give the anti-tubercular treatment in the community, which will be observed by the community volunteer that they're taking the medicine, because it's a 6-month therapy. So you want the patients to comply with the drug. And how can you ensure the compliance? This somebody observe directly. And Bangladesh is one of the most successful the country for the DOTS according to WHO, because almost 90% of the TB patient received the kind of the treatment when the health worker was. So it's efficacious and effective, available, accessible, it's free, it's well implemented. Next. But the problem is, whole program is based on the pulmonary TB. So sorry, I'm coughing. It's not COVID or TB, but when you cough, so there's the community health worker that they were trained to identify the patients with cough and then collect the sputum and then test it for AFB, acid fast bacilli, and then the health worker is the treatment. But 15% of the all TB patient is extrapulmonary. So when I did a study that we looked at 65 extrapulmonary TB patient, and I looked at their care pathway, that did they go to the DOTS center where they are offering the tuberculosis treatment, and you can look at that the pathway that there are the pharmacy, private facility, informal provider, government facility, so that the patients actually visited 11, 20, 25 provider, they went to the drugstore, then they went to the informal quack doctor or who are not trained, then they went to the private doctor. So this whole that the care pathway, they were lost, and when they reached the DOTS therapy, when they were diagnosed as an extrapulmonary TB cases, many cases it became too complicated or spreaded. So although it's a very successful intervention, but you can see that the government and the NGOs, everybody was focusing on only cough, the pulmonary lung TB, the pulmonary TB, not the extrapulmonary TB. Next. So next, I think you can click on, I just want to show the implementation gaps. So you can see that there are a certain intervention which is not developed yet, we don't have good intervention for the eye diseases, because which is very common, not only the refractory error, but there are a lot of the eye infections, but we don't have any intervention. Then intervention, those are tested, but not implemented. So we have this cool roof. We did the randomized control trial, but it's not scale up. We have spoken to different NGOs, but nobody is interested. So we tested it, then it showed that it reduced the temperature, 4 or 5 degrees a lot. But it was not scale up. Next. There's and their intervention not implemented as intended. So you can see that medical treatment loan, they just started it without any community mobilization, without its clear information. The benefit package was very poor. Next. Their intervention was not sustained for a useful period of time. So their intervention that you do, but it was not sustained for that long time, because there was not much more fund. They did not have the fund, or the government was not, or NGO, the blood NGOs were not interested to scale it up. Next. And also they're not scaled up. So not sustained, that it was not sustained, but also it was not scaled up because of the funding problem. So there are a lot of levels there could be implementation gap. Next. So next, so that how the implementation, research and knowledge translation, you can see that the pathways of discovery to delivery. So that when there is the problem identification, you can look at the problem identification, then where we define and we discover the problem, then we generate the solution. So we have to the program design, which should be sustainable. Then we do the pilot testing for efficacy and effectiveness trial. Then we deliver it as a routine delivery to the people, so population. So that's the kind of a pathway of when you have a problem to the delivery. And that's the knowledge we gather through the research or the pilot intervention or RCT, that's transferred or translated into the policy to the routine program. Next. So the implementation research are talking about what are the implementation gaps. So what is the aspiration for the in the future global health? Next. So I believe that this is implementation science. That's the routine delivery program. That and implementation science needs to be married with the big data and machine learning, because we do the research, but think about the most of the data we gathered in any country is the routine data, routine service delivery either by the government or the private sector. And that's the big data, because thousands of people come and receive that service. So if we want to marry that this implementation science, looking at the implementation strategy and utilize that based on those big data and machine learning, I do think that it will it will tackle the global health threat. It will reduce the equity, and it will also improve health outcome.